Okay, so good morning and good afternoon, depending on where you are. My name is George Manawata. I'm your moderator today. I'm also a volunteer pulmonologist of MAVEN Project. I want to welcome you to today's session on evidence-based management of acne, which is made possible by a partnership between MAVEN Project and Direct Relief. It's my pleasure to introduce our speaker today, Dr. Ginette Okoye, Professor and Chair of Dermatology at Howard University College of Medicine, located in our nation's capital, Washington, D.C. MAVEN Project and Direct Relief are extremely grateful to Dr. Okoye for not just today's session, but also for the multiple other educational sessions on various dermatologic topics that she has volunteered to provide in the past and into the future. And with that, Dr. Okoye, the microphone is yours.
All right, thank you so much. Always nice to be back with this group. And today we're going to be talking about acne, something that you probably see quite often, and might be able to put some of these tenets into play today or even next week. So these are my disclosures. And you already heard about the CME. You get one credit for today. So as always, I always like to start with a little bit of the pathophysiology, because I want you all to leave this lecture not having to memorize medications to use for acne, but to really be able to select medications based on what you know about how acne works. So we'll spend some time talking about the pathophys, and then we'll jump right into acne management using some cases. So I think this is a really nice cartoon that describes how acne progresses. And so it begins here. On this first diagram, you could see these little bumps blocking the follicular opening, right? So this is a hair follicle. This is a cross-section of the skin. This is the hair. This is the sebaceous gland, where your oil glands, basically. And so what happens in acne is patients develop basically occlusion. They have keratinocytes, dead keratinocytes, sebum or oil, bacteria, make a plug at the very top of the hair follicle here. So you hear people talk about their pores being clogged. Well, it's true. That is exactly how acne begins. And that's called a comedone. So let me show you some pictures. This is what's called a closed comedone, which is basically that area of occlusion starts below that. It starts to expand a little bit. It stretches the hair follicle. And if it's covered by regular skin, that's called a closed comedone. But if it stretches enough that some of the dead keratinocytes and sebum gets exposed to the air, that turns black. It basically oxidizes upon exposure to the air, and you get a blackhead or an open comedone. So these are some nice photos of closed comedones here, just these tiny bumps. And here is a nice example of someone with open comedones or blackheads. After this, in some people, what proceeds after this is below the level of that occlusion, the hair follicle continues to fill. It fills with more sebum, bacteria, etc. And eventually that follicular epithelium ruptures a little, and out spills dead keratinocytes, bacteria, etc. into the dermis, and it sets up an inflammatory response. The immune system comes in to see what's going on. You have neutrophils coming in, and so the patients develop pustules and inflammatory papules that are a little bit larger than comedones. They could be red, and they can even be symptomatic. Some of them can be a little bit painful. And then in some of our patients, that immune response is very robust. And we can't always predict who those people will be, but often there's a genetic component where the inflammatory response is so large, the lesions are larger, they're deeper, they can be more painful, and they're much more likely to leave behind scarring. And so these are the patients that we consider to have nodular acne or nodulocystic acne. And these patients almost invariably will need systemic medications, as we'll talk about in a few. So there are four main pathogenic pathways in acne. The first is this stickiness, right? This abnormal stickiness of the keratinocytes that causes this follicular occlusion or clogged pores. The second is androgens. Androgens drive sebum production. So the patient gets more oily skin, more oil, more plugging of the follicle. And then the fourth pathway is C. acnes proliferation. So C. acnes is a specific type of common cell bacteria that lives on our skin. It loves to live inside our hair follicles, and it feeds on sebum. So you just have this kind of circle, this pathway. So you have more androgens, more sebum, which the C. acnes like, so they're proliferating, and you're just in this vicious cycle. And so the best acne treatments really go after two or more of these different pathways, as you'll see. So the way to go after the abnormal stickiness of those keratinocytes is to use a retinoid, either a topical retinoid like tretinoin, we'll talk about those ad nauseum in a few minutes, or a systemic retinoid like isotretinoin or Accutane. If we're going after the C. acnes population or trying to decrease the C. acnes activity in the skin, then that's when we use antibiotics for acne, either oral antibiotics or topical antibiotics. We can try to decrease the sebum production in the skin, and we can do that in two ways, either directly by topically using retinoids. They work on the sebaceous gland and decrease oil production, or we can try to block androgen production in the body and thereby decrease sebum production in that way. So we'll talk about all of these, but the key here to remember is that you're going to have more success if you use more than one class of medication from this menu, so to speak. Okay, so let's jump into our first case. So this is a 16-year-old who presents with what he calls blackheads on the forehead and on the nose. He tried an over-the-counter acne face wash. Usually those contain salicylic acid, some contain benzoyl peroxide. He wasn't sure, but he just feels like he hasn't had any improvement. So you can see these nice open comedones here, so you know that those hair follicles are plugged. He even has some closed comedones over here. And then here's a nice little inflammatory papule, but really just one. The majority of his lesions are comedones. So how do you approach managing acne? I think the first thing is to classify it. What type of acne am I dealing with? And I'll show you how I think about that. But the next step is to think about, well, what type of management do you want to do? Do you want to use topicals only in this patient for some reason, or is this someone who might need oral treatment? And for my patient population, I particularly have to think about what's accessible to them, what is affordable, because some of our acne medications, they have these really nice formulations with multiple drugs together in one cream, but they're brand name. And so, they're hard for my patients to get. It's not on their formulary. So would it be nice to get it to them? Yes, but we have to kind of think outside the box and do things differently. And I know we have similar patient populations, so we'll talk about that. And then there's some special considerations that you have to think about with acne. Is the patient pregnant? Are they trying to conceive? That tends to limit what we can do, but there's definitely still stuff we can do. Are they on hormonal therapy for any reason? That can exacerbate acne, and certainly some of the medications we use can block their hormonal therapy, which we may not want to do. And then you have to think about post-inflammatory hyperpigmentation. I see someone already asked a question about hyperpigmentation. It's a really important part of acne management, especially in patients with pigmented skin. The acne itself may be mild, but if it leaves behind pigmentation that lasts for 6 months, then that bumps up the severity in my estimation, and I'm a little bit more aggressive with that. And I'm also going to give them acne medicines that also help pigmentation. So we'll get to that. And then sometimes people have acne that looks pretty bad to us, but they don't really want to treat it. So I think you have to get a sense for whether the patient really wants to treat their acne or not. So how do you classify acne? How do you decide what am I dealing with here? Well, you could go as simple as saying, is this mild, moderate, or severe acne? And I've given you some examples here to get a sense for that. And that really is a judgment call, but I would involve the patient in that decision. So I've been wrong many times when I thought that someone's acne looked pretty mild to me, but the psychosocial effect on them pushed it into the severe category for them. And so I would make that decision together with the patient. So that's one way to think about this. And if you decide to use this kind of classification, which is easy to do in a busy clinic, Then the American Academy of Dermatology has specific guidelines for care of acne that follow this algorithm. Is it mild? Is it moderate? Is it severe? Now, this is in your handout, and you can literally follow this like a menu. And we're going to talk about each of these drugs in turn as we go forward. But I wanted to introduce to you a different way today to think about and classify acne. So I would say, think about classifying it by the type of lesion that you see. So for example, the patient on the left has a ton of blackheads, some whiteheads. That patient has what we call comedonal acne. So the issue with this patient is their follicles are plugged. So the primary medication you're going to use in this patient is a follicle unplugging medicine, which is a retinoid, right? They don't have a lot of inflammation. So you don't have to necessarily go after inflammation in this patient. First is the patient in the middle who has primarily inflammatory acne, where they may have a few blackheads, but the majority of lesions you see are red, pink papules or nodules that's leaving behind scarring. Right away, you know this person is probably going to need systemic treatment. And then the third type of acne is a very specific type. It's called hormonal acne. Hormonal acne tends to affect young to middle-aged women from about 25 to about 50, 60 years old. They typically will be pretty distressed because they'll say, I never had acne as a teenager, and now here I am with acne. But that's typically who gets hormonal acne. It's not teenagers, it's women a little bit later in life. The acne lesions tend to occur on the jawline, around the mouth, on the anterior neck. And these patients respond really well to hormonal therapy. And so you can get them better much faster if you're really directing your treatment at the type of acne they have. So for our comedonal patients, we're going to primarily use topical retinoids. Actually, you'll see everybody gets a topical retinoid because remember I showed you that cartoon. The primary issue in acne is the follicular occlusion. Everybody has it. That's how it started in everybody. So everybody needs to bust those comedones with their topical retinoids. So everybody gets a topical retinoid, but your comedonal patients, benzoyl peroxide blocks, opens up comedones as well. And your inflammatory patients, they'll need an antibiotic, topical and or oral. And then your hormonal patients will need either spironolactone orally, which we'll go through, or there's a new option called clascoterone cream, which is basically topical spironolactone, which works really well for this type of acne. And then these patients can respond nicely to oral contraceptive pills that are FDA approved for the management of acne. So back to our patient. So how would I classify this patient? Well, you could classify him as mild, but I would classify this patient as primarily comedonal acne. So he needs a benzoyl peroxide and a topical retinoid. So let's get into the weeds now with the topical retinoids. These are vitamin A derivatives, and they are comedone busters. If you leave here with nothing else, remember everybody needs a topical retinoid, even if you don't have acne, because they actually help decrease wrinkles. So, go ahead and get some. I'll show you where to get them. So comedone busters, everybody needs a topical retinoid. But in addition to that, they are anti-inflammatory and they enhance the penetration of our other acne medications into that hair follicle. So they overall improve the efficacy of all of your acne therapies. Additionally, topical retinoids treat hyperpigmentation. So if your patient is at risk for hyperpigmentation or they already have hyperpigmentation, you definitely need to get them on a retinoid to attack both issues. So now there's an over-the-counter retinoid, adapalene 0.1%. Adapalene actually used to be prescription until about maybe 10 years ago, less than 10 years ago. So it's nice that it is now so readily available. But we also have prescription retinoids. Tretinoin is the most common, and it comes in a variety of strengths, starting with 0.025%. I almost always start patients on the lowest dose of a retinoid possible because they can be tough to tolerate. They can cause dryness and irritation. So you want to start low and graduate them every few months. There is a stronger adapalene, 0.3%, that's prescription. And then there's tazarotene, which is even stronger, should your patient need to go that high. I would never start somebody on tazarotene because you're going to get a face full of redness and scaling, and they'll never do it again. So don't start there. And then there's some really nice combination products that combine a retinoid with another drug that we use for acne, like benzoyl peroxide, or a retinoid and clindamycin. They can be they're really nice, elegant formulations. Patients love them, but they're brand name. And so I generally don't get to use them very often, but they are really good options if your patient can get them. Let's talk about how to teach patients to use topical retinoids, because this is really important for them to tolerate it. And, if they can tolerate it, they're just going to be that much more adherent. So the first thing I tell patients is to use a small amount, a pea-sized amount, or a kernel of corn-sized amount to the entire face. So they'll put that pea-sized amount on the fingertip and they dab it multiple places on the face and then rub that in. Make that little bit enough for the entire face. And that's really important so they don't use too much medication. I'm also really specific with patients to say, use on your entire face so that they don't end up just using it as spot treatment. And then I tell them to start every other night. This is a nighttime application because the sun, ultraviolet light, can inactivate tretinoin. So they apply it at night. And after they do it every other night for about 2 weeks, then they can try increasing it to every night if tolerated. I definitely have patients who can't even do every other night. They get dry and irritated, in which case they do it twice a week. Twice a week is better than none. And so I tell patients, I just give them that flexibility to play with it, play with the frequency until they're able to tolerate it. As I mentioned, start at the lowest possible dose in any given retinoid and then titrate up every few months. And then I also tell patients to use a moisturizer, any moisturizer they like, on top of the retinoid. Or they can actually put the moisturizer on first and then put the retinoid and and then put a retinoid on top and then put a moisturizer on top. We call that a sandwich. So moisturizer, retinoid, moisturizer. It really helps them tolerate it a little bit better. The other thing is sometimes your patients are buying things over the counter that they heard from their friends or from TikTok, a scrub or a mask or, other products like that. But those can be irritating in combination with the topical retinoid. So I'm really specific. When you're using this retinoid, we're going to treat your skin really, really gently. No scrubbing, no rubbing, just a gentle cleanser and your moisturizer. Again, just to get them on board and get them tolerating it. You do need sunscreen when you're using topical retinoids. It can increase the skin sensitivity to the sun. And you do want to remind patients that they should stop a retinoid about 2 weeks before waxing or chemical peels or facials, because it thins the epidermis a little bit and can make them a little bit more susceptible to side effects from these procedures. And so just go slow. It's better to have slow improvement with your retinoid than to end up with a face full of retinoid dermatitis, which basically looks like a rash. It's an irritant dermatitis. It's like eczema. And in patients with brown skin, that irritation can then develop pigmentation. And so your patient can end up being really unhappy. And more importantly, they would stop using a medicine that really works. It really is the workhorse when it comes to acne in terms of effectiveness. It takes a while to work. It takes about 3 to 4 months to really kick in. So I give them that caveat up front so that they know they have to stick with it a little bit. In terms of prescribing the retinoids, sometimes you can get some pushback from insurance companies, especially if the patient is over the age of 20, 25. Someone told insurance companies that people over 25 don't get acne. I'm not sure who told them that, but they think that you're trying to prescribe it for the cosmetic effect of the anti-aging and so on. So often you'll need a prior authorization. So to help save time, my suggestion is in your note, just talk about what they've tried and failed. Over-the-counter benzoyl peroxide, over-the-counter salicylic acid, that counts. for the prior authorization, and use the full term acne vulgaris in your note, and use the acne vulgaris billing code, which I put here. That also makes a difference for prior authorizations. There are other codes for acne that are unspecified codes, and that can actually kick the prior authorization out in some cases. And then just use your patient's formulary. Let me show you our formulary for DC Medicaid for this year. Sometimes it doesn't necessarily make intuitive sense, right? I would think that the generic option would be on our formulary. That's not true. So Retin-A brand name is preferred on our formulary. So if we write for tretinoin generic, we actually have to end up doing a prior authorization. But if we wrote for the brand name, we wouldn't. It's just not intuitive. So do check your patients' formularies if you see, if the vast majority of your patients have a specific insurance, you can save yourself a lot of time. And if for some reason tretinoin won't be covered, or you just don't have time for yet another prior authorization, I absolutely get that. Just use over-the-counter Differin. I really talk it up with patients because I think sometimes patients get a little disappointed when we recommend something over-the-counter. But I tell them this used to be prescription. It recently went over the counter, so more people have access to it. It works really well. And if the patient has tried adapalene or Differin, then it's actually easier the next time you want to do a prior authorization. And adapalene is not inferior to tretinoin. It's actually better in some cases. It's less photolabile, meaning ultraviolet light does not inactivate adapalene. So patients could do it in the morning, they could do it at night. Sometimes if they can tolerate it, they could do it twice a day. I wouldn't recommend that, but I do have patients who can tolerate that. And it's very lipophilic, so it penetrates the hair follicle very quickly, goes right through that sebum, and it draws in the other medications with it, like your antibiotics or your other acne therapies. So it's a really good medicine. So talk it up with your patients. Another option, if the patient really doesn't want to do Differin because it's over the counter or they've tried it before, then just go to goodrx.com. It's actually pretty affordable on GoodRx. This is a 20-gram tube. There's a difference here. There's a 45-gram tube, which is double that cost. But a 20-gram tube lasts most of my patients 2 to 3 months. So for $18 on average in DC, they can get medication for 2 to 3 months. So in derm, we would think like an acne visit is pretty quick, but it's not, because we're always having these conversations with patients because we want them to get the medicine. Because we just got tired of seeing patients back every 3 to 6 months, and they spent so much time trying to get their retinoid from the pharmacy and with the prior auths, and there were all these delays to care. So we just tried to work around the prior authorizations where we can. So in our case, our patient, the 16-year-old, my plan was to give him a topical retinoid, which we talked about, and benzoyl peroxide. So let's talk about benzoyl peroxide. This is an oldie but goodie. This has been around a really long time. Recently, there have been some concerns, though, about benzene production within benzoyl peroxide containers if you've had the container for a long time and if you've stored it in hot environments like in a car or in the shower. So we are talking to patients about that, recommending that they really replace their benzoyl peroxide bottle every couple of months and that they don't leave it in their car. Like, if they're putting it in their gym bag or something, don't leave it in the car. Don't put it in the shower. Just keep it at room temperature to keep it nice and safe. But BP is good stuff. It's bactericidal against C. acnes, right? That bacteria that is part of the pathogenic pathway of acne. It also is a comedone buster. It's anti-inflammatory. It reduces sebum production. So it literally works on all 4 aspects of, 3 of the 4 aspects of the acne pathogenic pathway. It also prevents bacterial resistance. So in many of our patients with acne, we're giving a topical or an oral antibiotic. And so it's been well demonstrated that if a patient is also on benzoyl peroxide, it decreases the risk of the cutaneous bacteria developing bacterial resistance to the antibiotics we're using. It is not necessarily safe in pregnancy, but it is over the counter, and I suspect some of my patients who are pregnant have been using this, but I wouldn't recommend it to a pregnant person. And so BP comes in many forms. You could get a gel, you could get a cream, but I like the washes. They come in many different strengths, anywhere from 2.5% to 10%. I have no relationship with any of these companies. I just wanted you to see some of the different brands, because if you tell a patient, go get benzoyl peroxide wash, they're not going to find that word on a box in CVS. They're going to see these brands, and they're going to have to know to look at the back of these bottles and look for that as the active ingredient. Because any given brand, for example, Clean and Clear has benzoyl peroxide. They also have salicylic acid washes. So again, be really specific with patients. You're looking for benzoyl peroxide. And you can see they have different strengths here. I don't think we ever really need the 10% benzoyl peroxide. 4%, 5% has been shown to be just as effective as 10%, but less irritating. So that's where I tend to stay. There are a couple of benzoyl peroxide spot treatments. Those are nice for people who have generally well-controlled acne, and then every now and then they get an inflammatory papule, and they can just apply the benzoyl peroxide there for a few days. But for the most part, when I'm saying benzoyl peroxide, I'm talking about a wash for the entire face. And it could also be used on the body, so the chest and the back. Benzoyl peroxide also comes in combination with antibiotics, and these are generic and so widely available to my patient population. So there's benzoyl peroxide and clindamycin, 1%, and that works really well. I would have a patient use that in the morning and use their retinoid at night. The one thing, though, is they sort of interact with each other, and the benzoyl peroxide breaks down the clindamycin. So every 2 months, they need to replace that little tub because it's not as effective after a couple of months. And then there's benzoyl peroxide and erythromycin, which is a much older drug. It's considered to be less effective because there's a lot of C. acnes resistance to erythromycin, but sometimes it's the only option in my patient's formulary. And so I think it's certainly still better than nothing. And since we don't use topical erythromycin that much anymore, I wonder if some of those resistance issues aren't as big a deal right now. I don't know. It seems to work just fine. And then in the lucky few patients who can get this combination of benzoyl peroxide and a retinoid, that's really nice. These combinations are great for like teenagers, right? Or teenage boys in particular in my setting, who they don't necessarily always want a regimen of a wash and a cream in the morning and a cream at night. They want one cream that they can do once a day, and they're just going to be much more likely to be adherent with that. Or like a busy professional, or somebody who really just wants a one-shot deal. This is a great option. Benzoyl peroxide plus adapalene, and you can titrate the strength. I would start with the adapalene 0.1, and then if they're doing great and they still need some more efficacy, you can go up to the benzoyl peroxide 0.3 adapalene mixture. What's nice about this particular brand is it's approved for 9 years old and older, whereas the other retinoids are approved for 12 years old and older. So, sometimes if kids get started a little bit earlier with acne, this is a nice option that should be covered because of if they're on the younger side. One thing I always tell patients is benzoyl peroxide will bleach your towels, because sometimes they get really concerned when they see their towels bleaching. They worry if it's going to bleach their skin or their hair as well. It won't. But, just tell them use either white towels or towels they don't care about too much. There's a small risk of someone developing an allergy or an irritant dermatitis to benzoyl peroxide, but it's not really common, and it can also increase photosensitivity a little bit. But those patients are probably going to be wearing sunscreen anyway because they're using benzoyl peroxide and a topical retinoid anyway. All right, so back to our case. So we said he had mild or comedonal acne. I would give this young man benzoyl peroxide 4% wash and tretinoin 0.025% cream. I would see them back in 3 to 4 months, see how they're doing. And if we still need a little bit more effectiveness, and I'm convinced that they're getting it on almost every day, then we can bump it up to 0.05% or double the strength of the tretinoin and keep pushing forward. All right, so here's another case. This is a 20-year-old who says his acne is worsening on the face, the back, and the chest. We've already given benzoyl peroxide and clindamycin combination gel and over-the-counter adapalene, and he did that for 3 to 4 months, and actually not just no improvement, but it's actually worsening. So how would you classify this patient? Well, I would say this patient has moderate to severe acne. The lesions are pretty nodular. Look at this pretty large, deep one here. It's eroded on this side. And he has pigmented skin, so chances are he's going to get a lot of hyperpigmentation that will, cause some psychosocial impact down the line. Another way to classify this patient is to say he primarily has inflammatory lesions. So oral antibiotics, benzoyl peroxide, and a topical retinoid would be my choice for this patient. So you're upping the ante, right? So the patient with the previous patient had topical retinoids, benzoyl peroxide. This patient, you're adding on the antibiotics because of the inflammatory component. So the typical antibiotics for acne are doxycycline and minocycline that you take twice a day with food. Taking it with food really decreases the risk of nausea. And when patients go to the pharmacy, sometimes the bottle says, take on an empty stomach. So I am very specific telling patients, take this with food. And I tell them, if you don't take it with food, you're going to be really sorry. You'll feel really sick. I spend time kind of talking about it so they remember. And then I put take with food when I write the SIG on the prescription. It really makes a huge difference. And then if they take it with dairy, the calcium in milk or yogurt binds somehow to doxycycline and decreases its efficacy. There is a real risk of photosensitivity, especially in people with lighter skin with doxycycline, to the point where if I have teens on doxy for their acne and they're going off to camp, I'll actually stop the doxycycline for a few weeks because they can really get a bad sunburn on this medication. Minocycline has a lower risk of that photosensitivity. It's less likely to have GI side effects, but it has a kind of a bigger side effect profile. You can get some major hypersensitivity reactions and vertigo and headaches and all kinds of things with minocycline. So I tend not to use minocycline unless I have to. I think doxycycline for about 3 months is a reasonable course for acne. And if they're not improving at that point, we're moving on to another option. I don't want to leave patients on antibiotics for a year. And unfortunately, I see a good bit of that. I'm always concerned about their gut microbiome and the effects of long-term antibiotics. So as I said, 2 to 3 months at a time, and I encourage them to use probiotics while they're on the antibiotics and afterwards. And then I always use with benzoyl peroxide, again, to decrease the risk of the cutaneous bugs developing drug resistance to the doxycycline. There are some other options. I tend not to use these other options. Bactrim is a really well studied option for acne, especially in pediatric populations. Azithromycin can actually be dosed 500 milligrams 3 times a week and for acne, and it actually works quite well for people who might be allergic to doxycycline or can't tolerate it. And then there's a new drug called saracycline, but it's brand name, and my patients can't get it, so I haven't used it at all yet. But if doxycycline or minocycline is not doing the trick for acne for me, I'm moving on. I'm moving on to isotretinoin, which we'll talk about. So what about the topical antibiotics for acne? Clindamycin, erythromycin, those are the 2 most common options. And then there's a newer, it's not that new anymore, called Dapsone 5% gel. I just don't think it works that well, and it's really expensive. So I just put it here for completeness, but I wouldn't necessarily pick that versus over clindamycin. Again, use those topical antibiotics with benzoyl peroxide. Otherwise, you will breed clindamycin resistance. And I mentioned already that benzoyl peroxide is sometimes combined with these antibiotics for a nice kind of elegant 1-2 punch. And if your patient can get this, I think this is a great way to help adherence. Okay, so back to this patient. He has inflammatory acne that's moderate to severe. So him, I would give 3 months of doxycycline, 100 milligrams twice a day, a 4% benzoyl peroxide wash to use once or twice a day, and tretinoin cream. Even though his acne is on the severe side, I'm still starting low with that tretinoin. And then when I see him back in 3 months, we can double the strength if needed. But the plan here is if in 3 months he's not doing well, or he's doing well and we stop the antibiotics and the acne comes raging back, we're going to move on to isotretinoin, which is basically the oral vitamin A derivative equivalent of your topical tretinoin. It's a really great option for people with severe acne who are developing scarring or post-inflammatory hyperpigmentation, or people who, for me, I really like isotretinoin. I use it quite a bit. I think about the quality of life impact. So even if it's not as, I don't wait for it to get so severe that they're going to be left with scarring. If I can tell where this acne is going and the patient or their parents are open to talking about isotretinoin, I'm ready to give it because it is effective. It is a cure for acne if it's used properly. And by use properly, I mean you have to do Accutane by weight. So the goal is to get to 220 milligrams per kilogram total dose over the course of, say, 6 to 9 months. What happens sometimes is patients just get isotretinoin for 5 months or 6 months, and they may not have gotten to that goal dose. And that increases the risk of them having to do another course if the acne recurs. But if you get to 220 milligrams per kilogram total, chances are that acne is never coming back. And that's pretty cool. The other major advantage of isotretinoin is it's pretty safe if used correctly. The thing is, it has a bad safety reputation, largely unfounded in my opinion. The biggest issue with isotretinoin is the teratogenic potential. So people who can't get pregnant have to be on 2 forms of birth control. And there's something called iPledge, which is this national registry that we have to register on, the patient has to register on. And so it's a pain. It's a pain to prescribe, but, and it's to stop this teratogenic potential. But otherwise, really well tolerated, except for dry skin, dry lips. We do check patients for hypercholesterolemia on it because that can occur. But now evidence-based guidelines recommend that we don't have to check labs every month anymore. So it's, I'm spending a little time on it, not because I expect you necessarily to incorporate this into your practice, but if it comes up, or if you've given patients antibiotics for a few months and they're not getting better, I encourage them to get to a reputable online source to read about isotretinoin in preparation for their visit with a dermatologist. If you're interested in adding isotretinoin to your practice, you just have to go to ipledgeprogram.com and sign up. And you have to I will do some CMEs about how to prescribe isotretinoin, and I'm happy to talk to you guys about that specifically if it's something that you feel is a barrier for your patients getting to derm and getting this really awesome medicine. Okay, so our next case, this is our final case actually, is a 40-year-old woman with acne for several years. She never had acne before, but the week before her menses, without fail, she develops these painful red bumps on her jawline, on her neck, and sometimes around the mouth. So how would we classify this patient? She has hormonal acne, right? So this is usually adult woman, usually flares around their menses and always on the lower part of the face. So she needs either spironolactone, topical clascoterone, and everybody needs a topical retinoid. Sometimes we'll add a topical antibiotic for these patients. So let's talk about spironolactone for acne. This is, of course, off-label for acne, but we use it for its anti-androgenic properties. And I'm sure I don't have to tell you all the details of spironolactone, about how to prescribe it, as you guys most of you might be internists, but we start about 50 milligrams a day, and some patients need as much as 200 milligrams a day, but most fall somewhere between 100 and 150 milligrams a day for it to be effective. So of course, you want to talk to patients about the anti-androgenic effects. They can get some spotting between their periods. It can decrease libido for sure. And then we talk about the fact that it's a diuretic, and so it can cause side effects in that regard. And in the past, when we prescribed spironolactone, we would check people's potassium level pretty often. But again, evidence-based guidelines now say we don't have to do that in healthy adults who are under 50 who do not have renal disease. But some people will still do a CMP before starting therapy, especially if the patient is older or they have some kind of risk factor or comorbidity for kidney disease. This is absolutely not safe in pregnancy. It affects the normal development of genitals in a male fetus. So I particularly like it when my patients are on an OCP and spironolactone, because I know that risk decreases, but I don't require them to be on an OCP before prescribing spironolactone. But I differ in that way. I think some of my colleagues will not give spironolactone without an OCP. Speaking of OCPs for acne, there are 3 that are actually FDA approved for the treatment of acne. And the reason they are FDA approved is because they are either anti-androgenic, so drospirenone, the progesterone in Yaz, which is drospirenone, is anti-androgenic. It's like spironolactone. So I actually wouldn't combine those 2. I wouldn't do Yaz and spironolactone, by the way. You can do spironolactone with the other 2. Then the other 2, orthotricycline and loestrin, the progesterones in them, it's not anti-androgenic, but it's a lower androgen progesterone than the progesterones in some of the other OCPs. And also the progesterone-only birth control formulations or birth control devices like IUDs and the implantable device, the progesterone in these devices is very androgenic. And so they can actually worsen acne in some cases. And then topical clascoterone is a brand name, relatively new product that's basically being billed as topical spironolactone. Some of my patients have been lucky enough to get this covered. It works really well. It's twice a day application, but most of my patients can't get this. But my colleagues in private practice are using this quite a bit instead of spironolactone. So for my patients, I would do twice a day, and I would still have them do a topical retinoid at night. You could use it together with other systemics like spironolactone, antibiotics, even isotretinoin. As a matter of fact, towards the tail end of an isotretinoin course, one of my colleagues really likes to start adding clascoterone in the last month or 2, especially for adult women. And she really thinks that decreases their chances of recurrence. So I've been doing that for my patients who are lucky enough to get it covered. So for this patient, we started her on spironolactone 50 milligrams a day, and in about 4 weeks, we increased to 100 milligrams if the acne hadn't responded yet. It usually takes a couple months to kick in. Benzoyl peroxide 4% wash, and then I would start her on a nice low dose of tretinoin as well, because you can see she already has hyperpigmentation happening. And just want to give you a little some tips for post-inflammatory hyperpigmentation. So here's a way to combine your acne treatment and your hyperpigmentation treatment. So in the morning, the patient could do their benzoyl peroxide wash, a vitamin C serum, some of which are really quite affordable. You could pay anywhere from $8 to $200 for vitamin C serum, and the $8 ones work just fine. So the benzoyl peroxide wash followed by their vitamin C serum, which helps with hyperpigmentation and kind of brightening of the skin. And then I would have them wear a moisturizer with SPF 30, because we're going to be using retinoids and BP, which can make them more photosensitive. And then I tell patients they can wear makeup. Sometimes people with acne, they worry about clogging their pores, quote unquote, but most makeups actually have some like SPF in them, which is helpful. And it actually creates a physical barrier between the skin and the environment, which is not necessarily a bad thing. Plus, it allows them to camouflage any hyperpigmentation or redness that they might be, self-conscious about. So makeup, absolutely okay in the morning. And then in the evening, I tell them either use a gentle face wash or they can use their benzoyl peroxide wash again, followed by the topical retinoid. Then they could put the vitamin C again on top of that, and then a moisturizer that contains niacinamide. So niacinamide also helps with hyperpigmentation. And so, take a little screenshot here. You can even use this for yourself. This is a great regimen for like good skincare as well. Chemical peels work really well for hyperpigmentation, and salicylic acid chemical peels, which are easy to even administer in the office, or patients can do them at home. They have like lower strengths over the counter. Salicylic acids chemical peels specifically help acne and hyperpigmentation. And then I want to end with just a couple of special considerations. So in our trans masculine patients who are taking testosterone treatment, acne is a known adverse effect of testosterone. So, we would monitor them closely and we would begin treatment for the acne as soon as it develops, or preemptively prescribe some medication so that they can start at home and not have to wait for an appointment, because there's really good data that severe acne is associated with depression and suicidality in our transgender adolescents. So to me, it's a big deal. When I teach my residents about treating acne in our trans masculine patients, I tell them ask about acne on the chest and back. Don't necessarily have to examine that area if the patient doesn't want you to. And then we follow the same guidelines, but with the following considerations. So I would not use spironolactone. I would not use hormonal contraceptives in these patients because, of course, it'll decrease the efficacy of the testosterone. And then people on testosterone have a potential for hepatotoxicity, low risk, but the potential is there. So if I'm going to be using doxycycline or minocycline for a few months, and certainly if I'm going to use tretinoin, I will do more to monitor their liver enzymes than I would in a patient who's not taking testosterone. Thankfully, the iPledge program has more inclusive categories. That was not true even a year ago. So now it's patients who can get pregnant and patients who cannot get pregnant, period. Those are the two categories. It used to be binary genders, and we had to misgender patients in order to register them. So it caused a lot of angst, but they've done a better job now of being more inclusive. And then finally, patients always ask about this. Is it something I'm eating? Well, the one thing we have some data for is dairy. Dairy may worsen acne, especially skim milk for some reason. I don't think we understand why skim milk versus full cream milk. I'm not sure, but it's a thing. And so if patients are interested or willing to make a dietary change, that could be a temporary change they could make and see if they see an improvement. And if not, they can reintroduce milk if they wish. And then there was a nice recent meta-analysis suggesting that oral probiotics may be a good adjunctive treatment for acne. And, targeting the gut-skin axis is actually a pretty powerful tool in the management of most inflammatory disorders of the skin. But there were specific strains studied specifically in acne, Lactobacillus rhamnosus, and plantarum. So not all probiotics are created equal. If you're going to recommend probiotics, give them these two names, so they can look in the back of the bottle and see which strains are specifically included in the probiotic they're planning to buy. And then this can be helpful. It can absolutely be helpful. And so in summary, I think acne is worth treating if the patient is interested. It's associated with low self-esteem, depression, and even suicidality, especially in young people. I would avoid using oral and topical antibiotics without using benzoyl peroxide, if possible. Topical retinoids, are the key to long-term success. They take a while to kick in, but they are going after the inciting issue in acne, which is follicular occlusion. So you really want that on board. I would try not to use oral antibiotics for more than 3 months. If they need it for more than 3 months, you need to escalate therapy and either do some hormonal treatment or do isotretinoin or refer them out to get that done. I would try to refer early if you have that opportunity to dermatology for isotretinoin. And if you are going to do that and the patient can get pregnant, then I would get them started on an OCP while you're waiting for the referral, because they need to be on that OCP for at least 30 days before we can start isotretinoin. So you'll save them a ton of time if you do that. They also need 2 negative pregnancy tests that are at least 30 days apart before they can start isotretinoin. So if you start them on an OCP and you do a pregnancy test, you are saving them several weeks of starting the medication. So please do that. Consider signing up for iPledge and offering isotretinoin in your practice, especially if your patients don't have access to derm. And then remember, our transmasculine patients, treat them early. Don't block androgens with spironolactone in this patient population, and keep an eye on their LFTs if you're using tetracyclines or isotretinoin. And if patients want to use integrative therapies for their acne, tell them avoid dairy and try a probiotic with those specific lactobacillus species that I mentioned. And with that, I'll end here and take your questions. Thank you.
Thank you, Dr. Okoye. That was an amazing talk, packed with information. Just as a reminder, everybody, you will be getting Dr. Okoye's information slide deck in a few weeks, when you also get the recording via email. We have a lot of questions. I'm going to start with the chat first. I think there's a question about hyperpigmentation and treatment. I think you covered that. There was also a question about when to use aldactone, spironolactone. I think you covered that pretty extensively. There was a question about men with facial hair and recommendations or guidance around shaving.
Let's see. Can I get a little bit more detail there? Let me see. Oh, what do you recommend for shaving in a patient with facial acne? Oh, that's a great question. I see where the problem could lie. If they have a lot of nodules and they're shaving, they can actually traumatize the nodules. So one option is for them to use facial depilatory creams. So these are over-the-counter creams that they would apply, leave on for 2 to 3 minutes, and then just kind of wipe the hair off. So I think that would be the easiest way. Another option is if they could just leave the hair, let it grow until you get the acne under better control, which could take, if you're doing antibiotics, could be in 2 or 3 weeks. And then an option that isn't available necessarily to every patient is laser. So there are some newer lasers out there that treat acne that will not affect the hair, but you can kind of treat through the hair, get the acne under control, and then they can groom as usual.
There's also a question about retin-A and the risk of depression, or in someone who's already got diagnosed depression, worsening depression.
I think isotretinoin probably. Yes, so there is a potential. It's the data is very mixed about this risk of depression with the use of isotretinoin. I'll tell you what I've seen. 3 times in my career, and I use a fair amount of this drug. I've seen teenage boys have like 180-degree personality change, where it is not subtle. I'll never forget, this father brought his son in, this great young man I met just 2 months before, and he came in a black hoodie, wouldn't talk, wouldn't look up at me. And the dad was like, I don't recognize this child. And so the recommendation in situations like that is to actually try decreasing the dose by half and see if that helps. And if not, then you discontinue. But for all 3 of those teenagers that I recall this issue being a problem, we decreased the dose. I got them down to 20 milligrams a day, which meant that they were on it longer, but they did fine. Because the thing that I'm always concerned about is the acne itself can cause depression. So I'm trying to keep them on, if I can, at the lowest dose possible to get the acne under control and then get them off as fast as I can. But in adults or even teenagers who have a known diagnosis of depression, if their depression is being treated, it's otherwise under good control, I don't hesitate to use isotretinoin. If they're actively depressed and not seeing anyone or not on any medication, then I'm more likely to try to work with their PCP, recommend a psychiatrist, talk to their psychiatrist before I will do it. But most of the time, we're able to use it.
Great. There's a question about can trans males that are on testosterone take finasteride for male pattern baldness?
I am not sure, but I would, finasteride blocks 5-DHT specifically. So I don't know. It might be specific enough that it might be okay. And I feel like I have patients who are on Propecia or the 1 milligram dose of finasteride. But I would, my instinct would be especially in the early stages of transitioning, I would not block androgens in any way. Perhaps once things are more well established, we could try a small dose of finasteride and see. But I wouldn't, honestly. I would just use something like topical or oral minoxidil for androgenetic hair loss in that case, because that is a known side effect of the testosterone therapy.
Okay. There are a bunch of questions in the Q&A. Does topical, I think you addressed this about topical spironolactone, whether it could require a prior authorization.
I see someone asked about the name of an affordable vitamin C preparation. One brand is Ordinary. Again, no relationship there. Their vitamin C is pretty affordable. And Vichy, Vichy, it's a little bit more expensive, but it's a really nice one.
Okay.